get out of here on a decent time today. So it is week 6. We are in that midpoint. This is when it's going to start to get rougher for you, all of you. You've got projects due for peds, for community, all of the exams, and then prepping for HESI. So it gets pretty rough. So continue to keep ahead, keep to know what's coming next so that you can prepare for it, okay? Again, I'll always send you reminders if something's going on and you're not caught up, just to make sure that you do. This week, we are going to go over hematology, immunology, and the child with cancer. Quiz 4 is open. I tell you to do it after class today. I do go over everything in lecture. And if not lecture, it's on the Kahoots. You will know. I mean, some students like to look at the recording again. That's fine, but it is covered in there. You have 2 case studies that are due Sunday and your NCLEX. And next week is your second exam. At 5:30 today, I am doing the first review. If you can't make it, of course, you're going to get it as a recording. I will be uploading it to YouTube, and I also put it on your announcement sheet. So you will have access to that information. And remember, whenever I put a recording up, I'm also going to be putting up the PowerPoint that goes with it. So you don't have to go back in your announcements and look for them. So help to try to keep you a little bit organized. So we will be doing the PowerPoint, and then we will be doing the Kahoots like normal. Next week, we will come to class after the exam. Usually it's about 20 after 4. I have about 44 or 45 Kahoot questions, which literally go over all the information, all those concepts you're going to need for next week's information. Of course, you'll get the PowerPoint. I've actually redone them a little bit, put some more pictures on them, added some slides where I've seen some deficiencies. So you will get that also so that you can review that. If anybody wants to go over that PowerPoint with me, let me know, and I could do that with you. It's not a problem. So let's go ahead and start with this week. Why did it do that? Whoops, sorry. It's teasing me. So hematology, immunology, when we think of those 2 things, we need to figure out, how do we recognize if there's problems? Well, number one, it's that history, that talking to the parent. Could it be that now the child is tired, lack of energy, looks pale, little yellow gums, or you feel like a buzzing in their chest, or they're always sick, or when they get cut, they're bleeding or they're bruising. Those things are hematologic and immunologic issues that usually presents. And then you take that information and figure out now what we need to do. So we're going to do a complete blood count. That's as simple as it gets, because the white blood cells look at infection, looks at immunology a lot, and then the types of cells. Also, it looks at hemoglobin hematocrit. See, maybe there's a problem with, low energy due to anemia. And of course, platelets, when it's low, we're looking at bleeding. So you'll see that history physical done. You'll see the parents talking about no energy. And as the children get older than infants, we start that I'm not eating all that stuff. They won't eat that green leafy vegetables and all the things that they should with iron in them. So you're going to see poor iron sources. Up to that point, we can give them, iron fortified cereals and iron fortified formulas, but then their diet switches. And as a toddler, they go through that physiologic anorexia, which means they barely eat if you try. And of course, if they're sick all the time and bleeding, we can tell. Now, anemia is the most common of all hematologic disorders, and it's just basically their blood counts are low. But what does that really mean? What are we going to see? Well, if you don't have cells, you don't have red blood cells, you don't have oxygen going around the body. So you have a decreased amount of oxygen going around. So a child with a little bit of energy runs around, burns up all the oxygen and now is tired, or has just got done eating as an infant, can't finish the food, and now, you know, they're tired because there's just no oxygen for them. In anemias, we're going to see different ones that show sizes of their cells being different. You know, we all know of sickle cell. That's one of them, but there's one that's also rectangular. So we're going to be discussing that. Infants do not make their own red blood cells till about 6 months. Many times we go and we do a blood count because maybe we're looking for infection. We might see hemoglobin hematocrit of 10 and 30 for an infant. This is actually perfectly normal because this is the point where they're going to start making their own cells. So there's different sort of anemias, whether it's decreased production or increased loss or destruction of those red blood cells due to something. So the first one is nutritional. We all know iron deficient anemia, not enough iron in the diet, not enough iron, you're not making the cells, and now of course your lack of oxygen and you're tired. The other one is B12 that we're going to talk about, and that's the intrinsic factor. So you don't have the vitamin B12. Mostly, how do we, take care of these deficiencies? Well, we either eat the right food or we do replacements of these both vitamins. Now, there's a decreased red blood cell production when your bone marrow fails. If the bone marrow's not doing what it's supposed to do, there's a couple different things. Now, the first one is aplastic anemia. Remember, A is without, okay? The most common aplastic anemia that you see has a decrease in white blood cells, red blood cells, and platelets. So it's all of the components. So this one is very difficult to manage. Also, if we have leukemia, leukemia talks about your white blood cells are being made and they're all immature. We do have an increased red blood cell loss when we have nosebleeds. In fact, nosebleeds is what brings children into the physician or the emergency room because they're having them too frequently. And they're like, why? We've done this, this, and that, and nothing's working. At this point, we'll be doing a CBC, and many times we will show some bleeding coagulopathy. Sometimes we'll find some mild hemophilia or something called ITP. Well, ITP is idiopathic thrombocytopenia purpura. Now, P equals platelets, purpura, platelets, decreased platelets. You don't have platelets, you're going to bleed. And we're going to go into what that means. And then DIC is disseminated intravascular coagulopathy. Means the inside of the body, the blood is just doing all crazy things. Very sick child, requiring even heparin and bunches of blood products. I'm not going to go too crazy into that because it is such a high level condition that even many nurses taking care of it don't completely understand it yet. Then we have intercorpuscle, which means the sort of cells, and we know sickle cell. Sickle cell means we have sickle-shaped cells, and they go away quickly. So it's an increased destruction of them. They don't last as long as they should. The other one that's probably a lot more dangerous is thalassemia. Now, sickle cell is African-American children, and thalassemia is those of Mediterranean descent. And these are your rectangle-shaped cells. So they're both different shapes of cells. Thalassemia is when these cells burst, increase loss, and the insides, including their iron and the oxygen, are burst, and they don't live long. So this child will be lacking oxygen and have too much iron in their blood. And we're going to go into that. And then we also have different infections, radiation, chemo that we get for different conditions that can also cause the red blood cells to be destroyed too quickly. Now we get this child complaining of being tired. We can see they look pale. First thing we're going to do is listen to a heart rate. Now, that heart rate is going to probably be bigger or faster. Why? Well, your body wants oxygen to go around. They need oxygen. It's nutrition for the body. And if they're not getting all of the oxygen they need, the heart beats faster. So now you have a heart who has less cells in the blood. So they bang off of each other. Normal ones, they don't because they're so close. But in anemic children, and it could be 5 and 15, 6 and 18. I've seen that low in some sickle cell children, not uncommon. And it just brushes up against each other. And this is where you hear that swooshing and the murmur. So as we listen to the heart rate, we hear that swooshing. Even before we do a CBC, we can say, yes, this child is anemic. Plus with the other assessments we see the pale, we see the increased heart rate, etc. We can tell. These children, because of lack of oxygen, will be more cyanotic. And because they're not getting nutrition of oxygen, there's going to be some sort of growth retardation in that. And if we don't correct this or try to correct this quickly, that heart's beating fast. And that heart is working hard. And if you let it work too hard, too long, we know what's going to happen is that the heart's going to fail. So that's what we're trying to prevent. So how do we manage anemia? Well, of course, first we have to determine that's what they have. The history to physical I've discussed. The CBC I've talked about. So initially, depending on where the hemoglobin hematocrit is, do we need a transfusion or not? Okay, we're going to be given that in some of these cases. Even sickle cell, when you get down to 6 and 18 and child looks tired and looks pale, in a sickle cell crisis, we're going to be giving that blood as they need to. If it is a nutritional, we're going to be telling the child to eat properly. And if we need to, we can give all sorts of iron products to a children. Now, child comes in, is really anemic. Could be, let's say they have a blood, nosebleed and they've bled a lot. Their volume is down. Heart rate's really elevated. Blood pressure, of course, is going to be a little lower. We're going to be giving some IV fluids to replace the volume that was lost. Just remember, if we had a hemoglobin of 6 and 18 before we put IV fluids on, after this child gets IV fluids, it's going to go even lower. You might even see it go down to 4 and 12. So just be very careful of that. And with that being said, these children need oxygen and they need to expend no energy, bed rest for these children, so that until we get those hemoglobin hematocrits up, this kid is saving the oxygen for the body. So as we assess these children, knowing some racial, ethnic background can tell us some clues, and the history, of course. And we always rule out a GI bleed by doing an occult blood, just to make sure that we're trying to look for something, and it could be a GI bleed. Children need to be prepared. You know how to prepare them. First, walk in, sit with them, get that little rapport, and play with the equipment. And now you can do blood tests and whatnot. And these children are going to be less afraid. I mean, if this children is anemic and this kid starts screaming and yelling to draw blood, they're expending energy that they don't have. They're burning oxygen they don't have. So we don't want to do that. And as we are managing these children, again, rest so that they're not taking away the oxygen from where it really needs to go. So iron deficient anemia is not enough iron. We know the infants do get iron fortified formulas in cereal if they're on formulas, or they're getting some sort of vitamins. Premature children get their own sort of formulas, which have all of this rich stuff in it. Now, adolescents, because of their body image and they want to look good and skinny and sexy and all those good things, they're not eating well. Also, they're so busy with social activities and schoolwork, they're not eating well. So the adolescents are at high risk for iron deficient anemia. The milk babies means when we switch to whole milk, there's no iron in it. And before that, they had iron fortified formulas if they're on formula, right? So if a child was an infant and only had milk, they're not getting iron. They're going to have iron deficient anemia. So All we need to do is change the diet, or we need to give iron supplementation for iron deficient anemia. And they need to be aware of it and continue with it so that blood levels don't get really low again. Sickle cell anemia is the first one we'll talk about. If you have two parents with just the trait, you will have each child that they born will have 25% chance of having that disease. And it is a recessive trait that is passed on from parents to child. Sickle cell is shapes of the cells are in sickles. And the problem with sickle cell is if we get slightly dehydrated and those vessels get a little smaller, those sickle cells can't go through bifurcations. And one sickle cell blocks the bifurcation and packs up. Blood doesn't get below, so you can have death of tissue and hypoxia of that tissue, right? Above, it's swelling because it can't get through. And then you have inflammation and pain and swelling there. So it affects both things. So pain is huge in these children. So with these children, how do we know a sickle cell crisis and how do we prevent this from happening? Well, we know that children, if they're up and they're exercising a lot and they're out playing sports, that's going to take some of their oxygen away. So these children really need to keep hydrated, keep those vessels open to keep the blood flowing. Sometimes it could be some sort of trauma that happened. Infection and fever is the biggest thing that causes sickle cell crisis. These family and children are told a fever of 100.5 or higher, they need to contact their pediatrician or go to the emergency room because they need to get an antibiotic immediately. We need to get that infection stopped. What does fever infection do? It burns fluid of the body. What happens? Dehydration, okay? What does dehydration cause? Smaller vessels. What happens? You start getting those sickling things. So stress is the other thing that causes a lot in sickle cell crisis. I know there's been many students with sickle cell that have sickle cell crises right before exams because they're just so stressed out. You know, it's something that happens, that stress can cause it. And again, dehydration is one of the biggest factors that causes sickle cell crisis. So we want to prevent it as much as possible. So we need to rest. You know, we can't just be out running for 2 hours straight. There needs to be some rest in there. And then hydration. Keep the hydration and electrolytes going in. Gatorade, Powerade, one of those. If we are already close to, you know, your sickle cell, and we start with the pain and the crisis, something for pain, giving that blood is needed because these cells die quickly. So hemoglobin hematocrits are low. It is not uncommon for a sickle cell child to come into the emergency room with an H&H of 6 and 18. That would actually be a pretty decent one. If it was 7, I'd be even happier. But they do start getting blood immediately in the emergency room. So as a nurse, what are we going to be prepared for? How can we relieve that pain the most efficiently and effective? Priority care, fluids. Okay, now how is fluids going to decrease the pain? Well, the sickle cells are in a vessel that they can't get through. You dilate the veins with fluids, the cells can start go through. Now, you're going to also give pain medicine because it does hurt. But number one is we're relieving why the pain is occurring. Dilating the veins, let those cells go through, give pain meds. And the other thing is put some heat on it. And what's that going to do? It'll dilate the vessels. So now we've dilated it with fluids, we dilated it with heat, we give them something for pain, and we're going to see that pain start to decrease. There is no cure. And we know that these children are immunosuppressed and they have to be very careful. So as nurses, we're going to hand wash really well, is what it means. And the bacterial infections is what causes the most death in young children with sickle cell. Children can live to be adults and they can live a pretty decent life with sickle cell. if long as they see fevers, getting to the doctor, making sure that they fight those infections, keeping hydrated, resting as they need it, and trying to decrease the stress of life, which we know is hard sometimes. So seek early intervention, don't wait. Children are given 1 dose of penicillin a day. It's a prophylactic dose to help try preventing, these sickle cell crises. They give it from about 2 months old to about 5 years old. And this is a preventative that we get. We try to let these children be normal, act normal, go out and play like normal children. But these children and the parents need to know that hydration and rest periods are key to preventing sickle crisis. So basically what I just said, rest, hydrate, electrolytes, pain meds, blood for anemia, and we're going to give those antibiotics as needed if they're infection, the prophylactic. And the one thing we monitor on these children is something we call the reticulocyte count, and it really monitors how well the body's producing cells. So it's an evaluation that we like to look at. And again, why do we give a bone marrow to a child with sickle cell? Well, I mean a blood transfusion. A blood transfusion has really rich oxygenated blood. So we are actually giving that child oxygen in the blood that we're giving and raising that blood count up to where it should be. Thalassemia is the rectangular shaped blood cells. And these have a short life. And what happens, these cells burst, and they burst in the blood system. And inside the cells, we have iron and we have oxygen. So these children will be lacking oxygen and have a lot of iron buildup in their blood, which can become dangerous. As I said, these are descendants of people who live around that Mediterranean Sea. There are 4 types of thalassemia. Mostly I'm going to talk about the major, thalassemia major, which is Cooley's anemia. And this is one of those conditions that this child literally needs blood transfusions to live. There's nothing we can do to make those cells last longer. We just need to, maybe there's the bone marrow that will work, but this child's going to need blood transfusions. Is it every week, twice a week, once a month? It all depends on the child. Now, when the baby is born, those blood smears look normal. So they look like they have normal cells. And then about 6 weeks old, those cells start changing and bursting. So they usually will show up. Now remember, it's carrying oxygen. What does oxygen do? It's nutrition. You don't have nutrition, what happens? Growth retardation, right? This kid's not going to grow as well as it should and tire easily because of no oxygen. So they usually show up failure to thrive, that their weight is not what it should be according to their age. We take and do a CBC, see what's going on, do the smear, we find the thalassemia that's going on. These children need blood transfusions to stay alive. They need the hemoglobin. There's no other way for them. But not only do they need blood transfusions to get the hemoglobin, which has the oxygen that they need to live, they also need to treat that extra iron that's been spewed in that blood. And we do that by giving iron chelating drugs, this desferal. And what it does, it binds with it and it's released through the urine and the iron is removed because iron can be toxic. So we have to get those iron levels down. Now, these children can live to be adults, but they need to get their blood transfusions. Now, this child is going from a good hemoglobin after a blood transfusion, and then all the cells die. Now there's a low one, so now we're anemic, and there is this ping pong going on, and that heart is working fast when the levels are low, and then can rest when it has the brand new blood in the body, that can relax. And Then remember, this kid is getting multiple blood transfusions. So how many antigens did this child get? And now how particular is the blood have to be for this child now? Because if we have a good blood type, it's easier to get blood. Now, if we get one of these rare ones, it's going to be harder. And if you have a really rare blood type, it's going to be a problem with these children. Many times they say, let's take the spleen out. We don't want any cells being made, and it can cause a sepsis. Or because of no oxygen getting to all the vital organs, you can have multi-organ failure. And as I said, maybe bone marrow is a cure, maybe. So care management, what do we need to teach these children? What do we need to be aware of? Well, they need to be compliant. They need to be compliant, getting transfusions as they needed. If they wait, remember that heart's working hard, can go into heart failure. And to take their iron chelation medications. Now, they also can get on a machine called apheresis. It's like dialysis, but it removes components from the blood, and we could take the iron out also with this apheresis, and it hooks up just like a dialysis looks. These children are going to be constantly in and out, constantly getting blood products. So to keep this child calm, explaining things, this is a family disease. This is something that doesn't go away. It's not going to get better. These children are in and out of the hospitals with all complications, whether it's from the blood transfusions or due to the anemia or the heart shutting down. So really lending a lot of support is a lot of what we do with these children, besides making sure that they, do their therapies and get their blood on time. Now, as I said earlier, aplastic anemia, A without. That means A means there's simultaneous depressions of forms of blood. So profound anemia, hemoglobin hematocrit are really low. Leukopenia, that means white cells are very low. And thrombocytopenia, remember P equals platelets, decreased platelets. That's the most common of all of them. There is another type, which is RBCs, and the other things are okay, which is actually a better form of aplastic anemia. But when we think of aplastic anemia, we think of all forms are depressed. So how do we treat aplastic anemia? Well, we try to tell the body to stop burning the parts of the blood by immunosuppressive therapy. The treatment is very similar to leukemia. And the management for this, in the end, is a bone marrow transplantation. And usually that can help correct aplastic anemia. Now we're going to talk about bleeding, hemostasis, and what about these clotting factors? Well, hemophilia, we all know factor 8, hemophilia. And what is factor 8? Well, in the body, there are certain things you need for the blood to clot. So you don't just keep bleeding. And these things are called factors. And there's multiple sorts of factors in the body. So this is an X-linked recessive inheritable condition. So mom gives this disease to the child. So mom and dad might have to go through genetics if they want another child. So what are the types of hemophilia that we know of? And I'm sure there's probably other clotting factors out there we haven't figured out yet. But there's factor 8, which is your classic. That's the normal one we think of. And literally it comes in a box and we put the fluid in it and mix it up and give it, and that's factor. And then there's factor 9, which is the Christmas disease. So it's either 8 or 9. That means if you have 8, you have factor 9. And if it's 9, you have factor 8. And there's another one called von Willebrand's disease. And there was a scientist who found another factor, so he named it after himself, von Willebrand. But this also is factor 8. So when these children bleed, or regularly they need infusions of a factor to stop bleeding. So how do we diagnose hemophilia? Is when you're bleeding. These children they start bleeding and it won't stop. Many times I told you it's a nosebleed that alerts parents to the problem with bleeding in these children, and it actually helps these children from bleeding and then multiple ecchymotic areas, etc. Now, a child with hemophilia falls down on his knee. That knee could break a little vessel and bleed all within that joint capsule. And if we don't stop that blood, it continues. What's going to happen to that joint? It's going to be destroyed. So now this joint, this knee, doesn't work. And if we have a lot of different joints it's getting into, these children will end up in a wheelchair. So we really need to stop it quickly. So when we're evaluating hemophilia, what will we see? We're going to see the low factor, whatever it is, and we can do factor 8, factor 9, von Willebrand's. We can see if they have that factor in the blood, so we'll see that. But we'll have a prolonged PTT. That's what we use to measure heparin. Same one, PTT, thin blood that you're bleeding, but platelets are good. And other factors that affect bleeding, the parathyroid, parathymone level and the fibrinogen level, both are all normal. So the PTT is prolonged. So we have a problem. We have a child fell on the knee. You can see it's bruised, it's painful. We're going to be giving this child a home infusion. Now, I had a little 9-year-old boy who literally fell on his knee and the knee was all bruised. And it was on the weekend, and the physician, they couldn't get a hold of, the hematologist. So they came into the ER. The father came with a little box of factor and all his equipment and asked our physician, should we give it? And because of what we saw, the doctor said yes. The father asked to give his own stuff and do it himself. And I had an orientee with me. And I said, that would be great. Can we watch? Better than most nurses did he do this. The little boy, the 9-year-old, showed the dad what vein to use, helped him hold the arm so that it didn't move. The father mixed it up, hand washed it, everything perfect, inserted the little butterfly. The little boy held the butterfly in place, and slowly he injected the factor. Took it out, held it for a long time, put a Band-Aid on it. And I looked at that father and I said, I couldn't have done that better. That was amazing. I said, you're an amazing father. He said, it's my son and I need to take care of him. Most fathers don't. It's usually the mother. I was so impressed. In the culture down here in Miami, it's usually the mother, not the father. I was, wow. Anyway, even my orientee was like, I couldn't have done that. I said, I know. That was really impressive. Now, sometimes in hemophilia, it's not that severe, and we can give desmopressin in a nasal spray. Where else have you heard DDAVP? We're going to hear it next week. It's diabetes insipidus. It can be used for diabetes insipidus or hemophilia, mild. So here it is here. And sometimes anticaproic acid can be given with it. So what is our prognosis? Well, there's no cure for this. This is something that they live with, and they can live normal lives as long as when they're doing these bleeding episodes and it's getting into joints, that they treat it quickly so that they preserve those joints and these children can do well. There is gene therapy coming up, but again, not totally approved yet, but I'm looking forward to that. So this boy fell down at home, 9-year-old, and he's got this knee that hurts. So I like the saying price instead of just rice. It's first of all, you should protect. Any hemophiliac shouldn't be out there riding bikes and playing football and things that they can get hurt and bruised with. So safe environment first and soft toothbrushes. If they get and fall down, by accident, of course, they should follow the RICE, which is first, stop, rest. Ice it, it constricts the vessels. We were going to put an ACE bandage on it, compress it. It's like putting a finger on a bleeding something and elevate it, just like we would do with a bruise or a sprained ankle. It's exactly what we're going to do. And again, making sure these parents know the importance of giving their factor when they see a bleeding like this going on, and doing the RICE also, resting, ice, compressions, and elevating it. Then we have idiopathic thrombocytopenia purpura. Remember, P, platelets. What is it? It's an excessive destruction of platelets. So what do you see? Well, if you do a CBC, your platelets could be 20, could be 10, could be really low. Any child that has a decrease in platelets, you are going to put them on bleeding precautions as a nurse. Platelets, you don't have them, child will bleed. What are you going to see with this ITP is the initials. So ITP, you're going to see a child who has fine little petechiae going on and some bruising. Now, that little picture there of the arm, you can have it anywhere, on the chest, the back, the legs, doesn't matter, which is like this little purplish little purpura, they call it, type of rash going on. And the parent's going to say, but this kid doesn't go out and play. Why is he bruising? Well, they're going to do a history, and they usually will find they have had a recent upper respiratory, some sort of infection in the last month or so. This can be acute or it can be chronic. So we can cure this, but sometimes you'll continue on as it'll be a chronic condition that needs to be followed. Now, how do we treat it? Well, we're going to support it by giving IVIG. So it's giving some immunoglobulins intravenously, and we're going to give some anti-D antibody to this child. And then you're going to see down on the bottom, sometimes corticosteroids. So steroids can be used to help calm down this ITP, calm down this platelet destruction in the body. So the prognosis depends. Sometimes it's going to last less than a year. Sometimes it's going to last more than that. So as a nurse, your child is ITP. How are you going to take care of them? Well, number one, protect them because they'll bruise easily. Platelets are low, bleeding precautions. You're going to have soft toothbrushes, no venipunctures. You also are going to be monitoring their blood counts, their platelets. What is the platelet counts? And we're going to be seeing, are they bleeding from their stool, from their urine, from anywhere, to be sure. And again, give corticosteroids as needed. Now, DIC, all I want you to know about this is an overwhelming, usually shock sepsis that's occurred, and your body's blood coagulopathy goes completely haywire, and thrombin is put out there, and fibrogen is made, and platelets are destroyed, but you have a thick and thin blood. It's really bizarre. All you need to know about DIC is a bleeding issue. It is treated with blood, platelets, FFP, and IV heparin. And that's about all I want you to know. In infants, we give exchange transfusions, which is great. We pull out their blood from one syringe and push it in at the same time in another, and that's called an exchange. We also do exchange transfusions in hyperbilirubinemia. So if the bilirubins are high, it's the same thing that we perform. I've done quite a few exchange transfusions in my life. Epistaxis, we've talked about it, and it's probably one of the first things that clues in that parent that there's a problem going on with bleeding. So first thing, remember, children feel like if they're bleeding, their insides is coming out and they're gonna die. because that's what kids do. So try to keep them calm. I put them in the parent's lap. I mean, where are you calmer? I want to be in the parent's, my mom's lap or my daddy's lap. Have them lean forward so that they're not swallowing this blood, and put pressure for 10 minutes. And then open it, see if they're bleeding. If it continues to bleed, you need to go get help for these children. HIV/AIDS is a viral disease. It is two things that we look at in the pediatrics is the mother to child. And then of course, adolescents should be abstinent. Sure, tell an adolescent that and they're going to do what they want. So teach them safe sex so that we don't have transmission. And that's what we can do for adolescents, and recommend them to go to, Planned Parenthood or whatever for even more information. School nurse, if the parents don't want to talk about it, and you as a nurse can talk to these children about safe sex. Now, mother to child. Mother is positive HIV. If she has gone and had prenatal care, she should be getting what we call heart therapy, which should be given at 22 weeks. And it's a highly active antiretroviral therapy. And what that is to give that newborn's immune system a boost, okay? And then immediately at birth, we are giving more antiretroviral therapy to the newborn, because we want that immune system to be the strongest. Remember, newborns at 6 weeks, they say any infection can devastate them. So please, antivirals as soon as we can. Now, as I said, newborn infants, goal to improve the immune function. Between 3 to 6 months, the most common opportunistic infection is PCP pneumonia, respiratory, and it can be devastating. So if we've improved their immune system, they'll get through this PCP pneumonia. And the thing about HIV and newborns is just because mom had HIV does not mean the baby's going to have it. I've seen twins, one has HIV and one does not. So it can be done. And I was like, well, why was one and the other? There's no rhyme or reason. They both were treated the same, but one converted to HIV and one didn't. So we know with HIV, it's education, especially for those adolescents, and as a nurse with, let's say, an infant that had HIV, protecting that infant's confidentiality, not having a sign, be careful. I mean, we know as nurses today that we should use gloves on everyone and treat everyone like they have an infection, not just those who do. So blood transfusions are given quite a bit in hematological or immunological disorders. We could give packed cells, platelets. The one thing as nurses we watch is for reactions. Remember, the first thing we do, if we suspect a reaction, and the biggest one I've seen most of the time is a spike in temperature, because we take vital signs before we start, 15 minutes after, and then every hour for up to 4 hours. And usually in 15 minutes is when I see a spike in the temperature. So when normal temperature, now you're 101. Turn off the blood and call the physician. And then I mentioned already apheresis. As I said, it's just like dialysis, but it removes components. And one of the things is that we can use parents' blood, and use those and get the platelets out of them for their children when they need it. So when both parents have a sickle cell trait, what is the chance that each of their children will have sickle cell anemia? Which one?
Is it B?
It is A, 25%. And this is when they have a trait, okay? Not one has, they both just have sickle cell trait. It's 25%. Okay, neoplastic disorders. This is in children, half of all childhood cancers are blood or blood forming organs, which means leukemia, which has to do with white blood cells, and lymphomas, which is your lymphatic system. So leukemia has to do with the bone marrow and the lymph system. It's the most common form of childhood cancer. It is more in boys, and its peak onset is 2 to 5 years old. So you have a child chronically ill, usually the pediatrician sends them into the emergency room for checkout, and we find their white counts low, and now we're telling a parent of a 2-year-old boy, or even girls I've seen, that they have leukemia. Now, can you imagine how these parents are going to react? So it's very important to say that most children survive, that it's usually quite severe complications that occur that they don't. The treatment today on leukemia is really good. It's just quite a bit intense, and it takes a time to get the cure. So what's the definition of leukemia? It is called an unrestricted proliferation of immature white blood cells in the blood forming tissues, which means the body makes immature white blood cells, which means they don't work. So no white blood cells, no immune system. So they're extremely susceptible for infections. The liver and spleen are the most severely affected organs. So what do we see? This child will come in complaining of bone pain, will be coming in feeling fatigued, feeling tired, not well. And this child will have bruising going on. It's usually those 3 things that we do see. So that's the history. We go ahead and we do a CBC, and we ask for a smear, which means they look at what the blood cells look like. And you could see that in leukemia, you're going to see immature white blood cells. You're going to see them just not look right. So we know they're not working. Next step, we're going to be doing a lumbar puncture to make sure it's not in the central nervous system, in the spinal column or the fluid. We want to make sure it's not there, or we can put chemotherapy in there also. And then we're going to do a bone marrow aspiration to look at the cells being produced. So we've diagnosed, we know what's going on. We've given them the diagnosis. It's either acute lymphocytic leukemia or acute monocytic leukemia. Now, what's the difference? Well, ALL, lymphocytic, is the easier one to cure. AML is a little bit more difficult, but they're both curable. That's what we've seen, that the ALL is the easiest one. Now, how do we treat this? Well, this child needs to go get an IV access. Usually it's a port put in, and now we have a permanent way of giving blood or antibiotics, drawing blood, or giving chemotherapy to this child without chronically sticking. So it relieves a lot of tension from that parent about sticking this child all the time. And the first thing we do is induction therapy. And this is the first 4 to 6 weeks of therapy. It is a combination of multiple chemos. And we give this for 4 to 6 weeks until we achieve remission, which means all but very little bit of cells are left in there. So we're giving it till it's wiped out. Then we put them on the consolidation and maintenance therapy. Those couple little cells will wipe out, and then we'll keep them in remission. So induction, we're giving this multiple chemos for remission, and then we wipe out a couple cells that are left and then put them on to reserve them for remission. Now, we can give a hematopoietic stem cell transplantation in some cases. It could be from anywhere. The autologous is from the patient's own stem cells. Many times we have that with now the umbilical cord blood, saving it, but many parents can't afford to put it in a bank to keep it. So then what is the best way to take care of these children in most usual way? It is usually from your siblings, the allogenic. And it doesn't have to be a relative, doesn't have to be the same blood type. None of that needs matter here, which is not like giving a blood transfusion. So the allogenic from siblings is actually the best one, seems to be working the best with them. Now, the stem cell transplants, you can go into graft versus host. So it's in the blood. So you can have the symptoms go anywhere. I think the most severe one I've seen that I really felt bad, it was a older adolescent, and she had a stem cell and her face was on fire. It was like the blood cells in her face were just burning. And she required, I can't even tell you how much Dilaudid I gave, hydromorphone I had to give this child because of this graft versus host. So again, we have a child, we have a port in, you got to prepare them for what's going on. Taking care of their pain is important. You know, I have children that are older that know they're coming into for a procedure, or they have a little fever, again, 100.5 and higher, get to the emergency room, same sort of thing. So these children will put little Emla cream on their port and put a Band-Aid on it and get ready, so that area will be nice and numb. And we do believe in everything we do in leukemia and bone marrows that we do, we're going to use everything to prevent pain. But be honest, we can't relieve all the pain, but we can do our best at it. In leukemia, we try to prevent infection, hemorrhage, because hemoglobin, hematocrits go low, platelets go low. Because remember, chemo doesn't just eat up the cancer, it eats up good cells, healthy cells too. So these children do require blood transfusion, platelet transfusions, and you need to watch them. They are a bleeding risk also. And of course, that anemia. Now, any of you want to be an oncology nurse with pediatrics, you can get big bonuses to go to hospitals. Once you have experience, some of them pay $20,000 sign-on bonuses. It's unbelievable. So just a thought in your mind. So, and I know it's hard working with children, especially if they're dying. I get it. But it's also very rewarding, giving what you can while they're here with us. And remember, a lot of these children do make it. It's just watching them in the in-between when they're struggling. Anyway, prognosis depends on their initial white count. Was it 0.1 or is it 0.01? I mean, normal white count should be what? 4 to 7, 4 to 10, 5 to something. 0.1, 0.01 is not uncommon for a child with leukemia. How old were they? And was it the ALL or AML? That's the difference, boy or girl. And because of the amount of blood that these children do get, because chemo does destroy normal blood, depends on what type blood you have. Do you have a easy to get blood, or is it more difficult? So children with cancer. Cancer in children is combination surgery, chemo, radiation. So what do we see with cancer? Well, very similar to what we just saw with a child with leukemia. You're going to see pain, you're going to see maybe fever, bruising, bleeding, and then if it's going on further, you'll see that lethargy, weight loss, anemia, and then maybe big lymph nodes. And sometimes because of all of this, you get vision changes. Now, one of the things with cancer is we're worried about immunosuppression and we're worried about infection. Infections can kill these children very easily. So knowing different lab values so that we can react quickly are important. So monitoring for septic shock in children, we're going to be looking at the neutrophil count. If we have a child with a neutrophil count less than 500, they're at high risk for infection. So we really need to make sure that We collect the specimens to find out what the germ is that's causing the infection and giving the antibiotic as ordered. And our priority, preventing infection, simple as good hand washing. This is what we do for all children, but especially with children that are severely immunosuppressed with low neutrophil counts. Hemorrhage can happen because platelet counts are really, really low. So again, giving them their platelets, giving transfusions, and helping these children as they're going through this therapy understand they can't do some activities, riding their bike, they can skateboards, playing football, soccer. These things can bruise them and can cause internal bleeding, and we don't want that. Remember, with anemia, they're not going to feel well. They're going to be tired a lot. So to preserve their energy. With chemo, they will have nausea and vomiting. They are using cannabinoids in children, and they're doing it very well. Works good. I've seen a couple documentaries on the way it's been used. I mean, even with seizures, they've been using it, and it works well with children. And to give antiemetics before we start therapy. You know, years ago, as I started nursing, they had to vomit before we could give it, which I think is ridiculous. We want to prevent it, because once you start vomiting, it's hard to stop. Their nutrition, because they don't feel well and they're nauseous, they're not going to eat. Remember, these children need nutrition in order to fight it. So we need to monitor their nutrition, and we do that by intake output, number one, monitoring height, weight, and then looking at protein in their blood. If they don't have enough protein in their blood, what's going to happen is their intracellular fluid's going to go extracellular. So you're going to have all of this tissue swelling going on, and we want to prevent that. So what are we going to give them for nutrition? High protein, high calorie, high fat. Give them the fattiest high protein calorie snack you can find. And this can help them. Their mouth can get full of ulcers, but it's GI tract. From the mouth to anus, anywhere it can be all swollen and ulcerated. So make sure that we give foods that's soft, bland, can't burn, their stomachs, so that they'll want to eat. And of course, if there are those rectal lesions, to make sure they get a sit spats, they do really work well. And you're thinking, well, if their mouth hurts, is full of ulcers, just give lidocaine. Well, if we did that, it would end up, give lidocaine, these children can choke, because now we've numbed the back of their throat too. And we don't want an aspiration pneumonia on top of all their other problems. Because of neurological problems and this thin blood that we're concerned with, low platelets, hemoglobin hematocrits, if this child gets constipated and bears down hard, they could have a stroke. So we want to give stool softeners. These children, some are so sick they're in bed. Just because they're children doesn't mean they won't get decubitus ulcers or foot drop. They will. So making sure we prevent that. And a lot of these chemotherapies can cause what we call peripheral neuropathy, which means you don't feel the nerves in your feet, and it could lead to problems with walking. Sometimes there's jaw pain. Just give pain medicine as needed for these children, and don't forget it. They get hemorrhagic cystitis, increased fluids, and watch their urine for their color. And of course, with chemo, you think children, you think chemo, you think you're going to lose your hair. Have them prepared. Many dads actually will shave their heads. Their hair just clumps fall out. Many of these families decide to shave their kids' heads early so they don't have to watch that. I used to bring in ribbons for these children, and I'd ask them, what color ribbon are we going to do today? And we would say, all right, let's do a couple, let's do rainbow. So we would do one around and a couple little rainbows, and I would put it on with the child, and they would say, yeah, I look just like my nurse today. And it helps them mentally. Those little things help. And a lot of them are put on steroids. Remember, there is Cushing syndrome. Cushing syndrome's that big face, the hump neck, and they are just swelled all over. Older children realize they look like that. So we can avoid a little bit with salt, but also give them, if they're in the gowns, put them in bigger gowns, or tell the parents to buy a size up on their clothes so they're not like, feeling tight and, fat in these clothes. Procedures that we go through, a lot of them are uncomfortable. The spinal taps, many times we will sedate them to keep them calm with just a little bit midazolam, some Versed. If they're going for bone marrows, we can, depending on the child, give as much as we need. We will be giving all sorts of lidocaines topically, and as we do go into tissues, we'll be giving it. And be honest with the child, saying, we're giving you all the stuff we can to help you with pain. You might feel a little bit, and tell them the importance of procedures. And many children, if they know and you've explained it in their level of terms, they'll understand. Again, pain, give them what they need for pain. And it's just not pain like morphine. We can give ibuprofen with that too, sometimes, or Tylenol would be a good choice if they have platelet problems. And remember, it's not just medicine, it's those hot packs or cold packs, or elevating the head of the bed, or giving them something to hug, or distracting them with an iPad, or a movie, or cards, or crayons, whatever it takes. And that can really, really help. Now we're going to talk about Hodgkin's and non-Hodgkin's lymphoma. Remember, these are lymph glands now. Now, Hodgkin's lymphoma is again in the lymph nodes, and it can metastasize all over the body. What do you see, and how do these children present? They present, and you're going to see lymph nodes that are swollen. Remember, we've learned that lymph nodes you should not be able to feel in a healthy child. But when we feel these lymph nodes, it doesn't hurt. So they're painless type of lymph nodes. And it's usually in the neck that we're talking these lymph nodes. So they're completely painless, but it's the size of them that brings them into the doctor for evaluation. If along with that, there is a lot of swelling going on, they could be coughing because of compression. And it can also cause them a fever, loss of their appetite, which of course is weight loss too. So we'll do a history on these children, and we'll draw a battery of lab works on them. And then how do we diagnose these children for sure? What they'll do is they'll put them under anesthesia, and they will do a biopsy of this lymph node. And if they see Sternberg reed cells, we know that this is Hodgkin's lymphoma. They do have great outcomes with this. They'll give radiation, chemo, and the one problem with Hodgkin's is it's a high risk for infertility. This is one of them that in the future, because of what they're doing to these children to eradicate this cancer, that they're not able to have children. And again, always prepare them for what's going on. And if you look at those marks there, those are for radiation. You never remove those marks, because that's where they need to go next time that they do radiation. Now, non-Hodgkin's is not those big nodules. It's very diffuse, okay? So you don't see those sort of things in these children. You'll have the same sort of symptoms, but you're not going to see the big things. A lot of times you will see the metastasis that's already occurred, and it's going to look like a leukemia. They do, again, go into the bone marrow, and they look for to confirm the disease on them. And of course, doing x-rays, CAT scans to see if they see anything within the whole body. This is an aggressive radiation and chemo. Again, they go through the same thing like leukemia: induction, consolidation, maintenance. And they will, as this intrathecals, they'll put it into the central nervous system, making sure we eradicated all of the cancer. Then we have brain tumors. Brain tumors in children, we usually see a child complaining of a headache, and vomiting. And it starts with maybe once a day, and then it gets more and more and more. So it's the progression. It gets worse. The symptoms become worse. As a tumor grows, puts pressure in the brain, you see more and more symptoms going on. But vomiting and headache are your two big symptoms. So we've diagnosed, you can do a simple x-ray, and we could see a tumor in the brain. And then, of course, CAT scans, MRIs, whatever they need to do to find out exactly where it's located. The outcome depends on where was it located and what do we need to take out in the surgical portion of this therapy that we have to remove from the brain. So we shrink it as much as we can with radiotherapy and chemotherapy. Now, post-operatively, this child is going to have, usually they'll have what we call a brain drain. It could be a simple Jackson Pratt, or it could be just a tube with a bag that we're collecting things. As nurses, we need to be very careful with post-operative care. Do we lay them on that side that had surgery, or don't we? Can we elevate the head of the bed, or can't we? So positioning is huge on these children, knowing what to do. We talk about children in bed in general that are ill, but children who've also had brain surgery, intake and output is vital. If we give too much fluid, you're going to cause swelling in the brain. Fluid management is huge. And again, these children hurt. They've had brain surgery. Make sure that they're comfortable and have this family understand what they're going to look like after surgery. And our goal is to have them get to be as much as they can be as an optimal functioning when they're done. And many of them have to go through therapy. Now, we have something called a neuroblastoma. Now we think of neuro, we think of it as only brain, but this isn't the case. There is a tumor that grows probably off the kidney that gets big, and it gets so big on one kidney that it crosses what we call the midline, and it can get really big. Now, that child in this picture, we can say something's going wrong, but many times it gets big and we don't see it. What we start to see is that they're get like ecchymotic around and swelling around their eyes, or you see their eyes start pushing out, or they start with the neurological issues going on. And that is already the metastasis of the tumor that's in the abdomen, because that comes first. So this is a very difficult tumor cancer to diagnose, because once you diagnose it, it's usually already metastasized. So these children go through surgery, outcome isn't great, but the thing is, it's not that common at all. Thank God. It's only about 6% of all the malignancies. So I've never ever seen one, and I'm glad I didn't, because it is a difficult diagnosis to work with parents with. And then we have osteosarcoma, which is a bone tumor. Now, this is on the femur, usually adolescents and boys. And this child will start complaining of pain in the knee, pain in the hip, that progressively gets worse and worse and worse. Then we start to see it, becoming more inflamed, more red, more aggravated. And if we continue to let it go on, we'll see now this is a cancer. So you'll start to see the anemia and the weight loss and infection. So how do we diagnose it? Well, first of all, it's a simple x-ray. And we'll just see like this little fuzzy patch on the mid shaft of the bone. And then, of course, we've got to go to the CT and the MRI, and we go and do a biopsy just to make sure that it is an osteosarcoma, because the treatment is very radical. So we'll do chemotherapy and we'll do surgery. Now, we have to remove the entire bone. The whole femoral bone is taken out. So if we take off the whole leg, there's really nothing to put a prosthesis on. So what they do is they take the lower leg and connect it up into the hip joint. So there is something there to put a prosthesis on. Our goal is to save the limb, okay? There are times that they have to do an amputation, but goal is to save the limb. Then there's Wilms tumor. Wilms tumor is another kidney tumor. Males ages 3 to 5, African American are the big group of Wilms tumor. It's a painless swelling mass in the abdomen, and it's something that's found when you're just changing a diaper and you see it there. I had a little boy after the Haitian earthquake be brought in by a religious group. They picked the child off the plane and brought him directly to the ER where I was in triage. Now, all of the paperwork was in French. I couldn't read it. The child spoke French, and this group of women who brought him had no idea what the problem was. So I said, okay, so let me do an assessment. Where do I place this child? What does he need from our emergency room? And I needed to put him in a correct area. So I did it, sat there with the kid, got him comfortable, because now I don't speak French. So I'm trying to parlez-vous français with him, but that's about all I know. And got him comfortable, did a set of vital signs. I listened to his lungs. I went to listen to his abdomen and bowel sounds. The left lower quadrant had a softball-sized mass. I had never seen it before, and I have no reason why I knew, but I knew it was a Wilms tumor, and yes, it was. So immediately I put a note, do not touch abdomen, to let the nurses know what I suspected. And they went and did an x-ray. Usually they're not going to do an ultrasound because that's the rubbing, right? Mostly it's the CT and MRI to make sure what's going on in there. And of course, they're going to do labs and a urine because it's off the kidney. So they'll do chemotherapy and surgery, sometimes radiation, but mostly just chemo and surgery. And it looks like this little incision there, the whole thing, and they take it out. They do it as quick as possible. Now, why don't we touch that abdomen? Well, it is a tumor mass, and it's very fragile, and little pieces could break off into the peritoneum. Now you've caused metastasis of the tumor, and that's why, okay? Postoperatively, because it's by that kidney and all of that intestines has been really moved around, we're going to monitor bowel function, infection, and urinary output to make sure that they're all working. But once it's done, they usually do very well. Rhabdomyosarcoma is another cancer, most common in kids 9 years and under. You'll see it in the eye, the ear, the nose, the mouth, a little tumor, and it could be just a chronic earache that doesn't get better. Or it could be the nose is running, and I don't know, we've done all these allergy medicines, and that's when they find it, and they have to just go in, they have to remove it. Retinoblastoma is basically what I call whitish glow or cat's eye. Ever look outside and there's an animal out there, when you turn the light on, you see these white little eyes moving around in the distance? Well, this is what this child will look like, but without being dark. You're going to see it in the light, and you're going to see it looks white. Usually this child's going to have visual problems earlier, but the treatment is removing the eye. They'll do the radiation, the chemo to make sure it's not spread anywhere. And then they'll do the surgery and take it out. Again, you see the purple marcation for the radiation therapy. So prepare the family. The last child I saw, I've seen one with it, and this child was either 8 or 9 months old. And the outcome, they lose their eye. If it's caught soon enough, they can do okay. And then they'll learn how to take care of their prosthesis in their eye. We have germ cell tumors. Mostly I talk about germ cells. I'm talking about testicular tumors. And usually in the testicles, you'll have a tumor. That's why men should be doing a monthly testicle check, just like women should do a monthly breast exam. Same sort of concept. I had an 18-year-old boy come in complaining of testicular pain, said he had pain in his testicle for about a month. Well, when we did a visual, because we had to check the testicles, it was huge. It was almost the size of a baseball. And when we did x-rays, it had already metastasized through his body and he died within 3 months. So testicular cancers are huge and need to be taken care of, any testicle pain. Liver tumors, sometimes we can take out a lobe. Sometimes we need to take out the liver. And again, chemo first. So cancer survival is better than it's ever been. Used to be, a death trap for everything, but today we're doing so much better than ever. So much research has been put on. We know that they're changing the chemos every day. And our goal always in cancer is to see a kid on Facebook with his picture that says cancer free, because we know the fight that these kids have put in, and so have those parents. So a lot of bad stuff there. But remember, it's not that the child dies or the child has cancer. It's what did you do for the child and the family? There's so much you can do for families. And even if they do die, you've touched their lives. And I know that they'll still, on my birthday, I get messages. And on Nurses Week, I still get messages from children's family. They'll make sure that they remember me at important things because of what I did when that child was alive. So you can make a difference. Pediatrics can be very rewarding, and you're going to cry too. And I can't tell you how many parents I've cried with. So who wants to win cahoots today? Anybody? Everybody's asleep today. Everybody's trying to get through community, I guess.
I don't even want to talk about community.
I know. All right, let's go ahead and do some cahoots. I think there's 44 today. Who else is playing today? It looks like a sunflower, but black-eyed Susans, which look just like that, is my favorite flower, which grows in the Northeast, wild. But I planted some in my backyard and they're growing. I'm so happy with myself.
I'm from Northeast PA, and they're like a nuisance where I'm from.
I know, they're like a weed up there. I'm
Yeah,
aware.
exactly. My dad's
They're
always trying to get
so
rid of them.
pretty alongside the road, because I lived in country. Alongside the road, they're growing, and I think they're pretty. But yeah, they are a nuisance. But I love black-eyed Susans. They're a wildflower. All right, let's get going. Hematology, immunology, and cancer. Which statement best describes a neuroblastoma? Remember I said with this one that it says neuro, but that's not where it starts. That's the metastasis, right? So diagnosis usually made after metastasis occurs. And remember, it is not common at all, thank goodness. Mercy went right up top. What is sickle cell disease? Two are close. So which is the best answer? So it does restrict oxygen because the production is sickled. So you don't have proper oxygen and these cells burst quickly. So they die quickly. What is a priority treatment for a newborn of an HIV positive mother? Priority. Priority is to improve that infant's immune system because they don't have an immune system. How are they going to fight and say, hey, HIV, go away? Because remember, not all infants are HIV positive. They can stop it only when their immune system is strong. What are symptoms of sickle cell anemia? And pick the best one. Hand, foot swelling, pain, vision, and delayed growth. Remember, there are vessels in the eyes, and you can sickle in those vessels in the eyes too. Can you imagine the pain that would cause? Oof. Sickle cells anemia affect which cells? I'm just making sure that you know which cell it is. Absolutely, red blood cells, thank you. Somebody's on fire there. What kind of hematocrit would someone with sickle cell have and why? There. So what happens in sickle cell, the cells die quickly. So your hemoglobin hematocrit are low. Remember that when I see children coming in sickle cell crisis, they're always with low hemoglobin hematocrit. Many of them require blood in the emergency room, even before they go up to their room. What is the treatment for sickle cell anemia? Remember, with sickle cell anemia, priority treatment is IV fluids. Stretch that vein, then give pain medicine and heat, dilate that vein. Let those cells be able to go through, which will relieve the pain. Aplastic anemia includes a depression of which cells? Remember, A means without. Like atresia means there's no valve. A, without. So aplastic anemia is RBCs, WBCs, and platelets. They say all cells. Most common type of anemia is? Iron deficient anemia, most common. Thank goodness not aplastic. That would be horrible for that child. And Mercy's back on fire again.
I almost hit that one just because it said
What
The most
causes
common, and it has all the blood, like the red blood
Oh.
cells and white blood cells and platelets.
what causes pernicious anemia? Remember pernicious, when you see that, always think intrinsic factor. That's how I've always remembered it. I think from nursing school, I remember that name. And it's all about B12 deficiency, and the body can't use nutrients because of the lack of this intrinsic factor. Which symptom is the single most common symptom of anemia? I mean, you could see all of the symptoms there. There's so many, but what is the one that will bring your children to you, whether to the doctor's office or the emergency room? And then you go, all right, let's go ahead and draw a CBC and see what's happening. And it's fatigue, tired. They're just not themselves. They have no energy. They're not, they're not acting right. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, thalassemia is destruction of those rectangle cells. They just burst. Treatment for thalassemia, blood transfusions, and taking care of that iron. So thrombocytopenia, as it's not that, okay? It's the platelets are okay. The cells burst and the insides go spewing into the blood system. So your oxygen is burst, it's gone, and then all the iron is there. So you need to replace the iron, and you need to get rid of the iron and replace oxygen. Only blood transfusions. The nurse is caring for a child who's died, and the parents asked to be left alone to rock their child. What should you do? It's probably one of the hardest things in nursing is to be working on a child really hard and they die. I mean, it's the reality of life. I've sat there and hugged parents and cried with them, and it's okay. I'm human. And you're absolutely going to give them that time. Just make sure that you give them the proper resources. Do they need clergy? Do they need, the social worker? Do they need you in there with them? What is hemophilia? I mean, you see a kid who's bleeding, can't stop. You do lab works. What are you going to look for? And say, oh, it's probably hemophilia. Remember, PTT, like heparin, prolonged, but the PT and platelets are okay. So the PTT is prolonged and the factors are missing. That's all you'll see. So then you have to go looking for the factors in the blood. And there are blood works for that too. What is thrombocytopenia? Remember, P stands for ITP, thrombocytopenia purpura. What is that P? Thrombocytopenia is when the platelets, they're not where you don't have them. They're destroyed quickly. They're gone. Remember, ITP is caused from some sort of infection, upper respiratory, could be acute or it could be a chronic. And we give IVIG, an anti-D, and sometimes corticosteroids. Now, ITP, unlike sickle cell, you don't need to give fluids, okay? Fluids does nothing. There's no clog in this one. So these children just get their IVIG, anti-D, and corticosteroids, and they do well. Thrombocytopenia can cause the following symptoms. Low platelets, what do you worry out for? Thrombocytopenia, P platelets, low platelets, what are you going to worry about? And that is about anything bleeding. Remember, any child with or adult with low platelets, bleeding precautions. Be careful with bleeding. So hemorrhage, bruising, nosebleeds. As I said, nosebleeds usually bring them in. A multi-select. Child with hemophilia is fallen, knee is swollen and painful. Treatment would include what? So we are going to rice. We're going to rest, we're going to ice, we're going to wrap it up, contain it, and we are going to elevate it. And we are going to give the home factor. No hot, because that will dilate the vein and make more bleeding. Exercise, more bleeding. What is the priority nursing action for suspected blood transfusion reaction? You hung a unit of blood, you take your vital signs, all of a sudden you see a rash, you see an elevated temperature. What are you going to do? We're going to turn it off, absolutely. Tell the physician, pack up the blood, send it back to the blood bank. A child is admitted with neutropenia. Which nursing action takes priority? What's neutropenia? So we are just going to wash our hands. Contact isolation means they have something I can get. Neutropenia means they don't have a defense. There's no immune system. So we want to protect them by washing our hands. Which symptoms would a healthcare professional expect to see with a child with leukemia? Well, what happens with leukemia? You have white cells that aren't working. Usually you have decreased hemoglobins, hematocrits, you see the platelets low. These are all common things when child finally gets care. So you'll be bruising, they'll be tired, and then the bone pain. Usually those three things is what you see. My next door neighbor had leukemia, and those are the three things that brought her to the emergency room. Your child with ALL has had recent lab results and the platelet count is 10,000. What are you going to do? What does that mean to you? Any child, any patient, platelets of 10,000, what does that mean? Yep, bleeding precautions, very good. You listened well. No IM injections, you're going to watch out for bleeding and you're going to be following those lab results. A child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. Remember Wilms tumor, males, ages 3 to 5, African-American. My little guy from Haiti that came over, he did well, by the way. He went back home. You're not going to touch that belly because it can cause metastasis, and we don't want to do that. Cancer of the body's blood-forming tissues, including the bone marrow, is called what? And that is leukemia. Yes, it is. We have our flower on fire. All the following are true concerning neuroblastoma, except what is not true? Starts out with the lump in the belly, which can get bigger and cross what we say the midline. It's in the adrenal glands. And by the time we know, it's because we're seeing that metastasis that's in the brain, you know, the eyes bulging out. And thank goodness it is not common. It's a rare type of cancer. Most common clinical manifestation of a retinoblastoma. So something about the eyeball. And it's what we call a cat's eye reflex. Remember, the eye gets white. If you're seeing an animal outside, you turn the light on, you see these glowy eyes out there. Same look. It's called a cat's eye reflex. It's that whitish glow. And the chicken laid an egg is up top. Immunizations cause autism, yes or no? Absolutely not. Immunizations prevent diseases. That's all they do. A child's complaining about those skin markings for radiation therapy. They should be told what? You need to leave them there. They're for the treatment. They must remain. Those marks tell that radiation machine where to point the gun at. And they take a lot of time to put those marks there. So do not remove them. And the chick is on fire. Multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. What does P mean? And what is ITP? What happens? When you have low platelets, ITP, P platelets, low platelets is bleeding precautions. You're going to no IM injections. You're going to watch those blood counts, going to give steroids as needed, but you don't need to dilate a vessel. They don't need IV fluids, okay? Is that understood? Sickle cell, yes, you want to dilate the vessels so the stuff, the sickle cells go through, but in ITP, that's not what's going on. So you don't need IV fluids, no. And the flowers up top. When distraction is used, it helps what? So distraction takes the focus away from the child's head getting into, I hurt and I'm scared, and it gives them an outlet, and it really works well. What assessment question needs to be asked to a child with possible rheumatic fever? Question from last week. I always give a couple from last week. Important concepts that you need to know. So rheumatic fever is caused from a strep throat that was not treated or undertreated. Treatment includes long-term antibiotics, and you can clear it up unless the valve of the heart's already been damaged. Signs and symptoms of asthma, another last week question. Coughing, shortness of breath, tight chest tightness, wheezing, a prolonged expiratory phase. Yes, yes, and yes. Good job. A multi-select. Absolute contraindication for nasotracheal suction include which of the following? As in, when do you not want to go in the mouth? Even looking at the mouth, these are things you should not do. it causes more swelling in the mouth. And some of these are because of the swelling. Asthma and irritable airway, that's okay, because sometimes it's due to secretions. But when you know there's swelling from croup, and then the croup, when it goes on too long, becomes epiglottitis, you know that all you can do is increase the swelling. So croup, epiglottitis, do not look at that throat. Iron dextran is given via which route? We give this for usually younger children with iron deficient anemia. It's a way to give iron. And because when we give this, it's an intravenous Z-track, it causes staining of the skin and it burns, we give it Z-track. So basically what I call lock and load, just put it in there, you know, pull the skin back, give it, and then you like lock and load it, and then it doesn't come out, stain the skin, and doesn't hurt the skin also. What cancer may present with painless, firm, and enlarged cervical nodes? And this is your Hodgkin's lymphoma, okay? Hodgkin's, you'll see that big, you know, remember the picture on the PowerPoint, big, big nodes, but it doesn't hurt at all. But that's what brings the mother in, because that's just too big. What's going on? Thalassemia major is primary treated with what? Cooley's anemia. How do we treat it? And we give blood transfusions for this. A higher iron diet? No. What happens is iron is released when these cells burst. So we want low iron diet, and we want to give iron chelation therapy medications to get rid of the iron because it becomes toxic. A yeast infection is an opportunistic infection of HIV. Yes? No? And absolutely it is. There's several of them, and yeast is one of them. You treat it with nystatin. Multi-select. Treatment of an osteosarcoma. Remember, osteosarcoma is the femur bone on an adolescent, usually a male. I mean, our big goal is to salvage the limb. We want to keep the piece on the bottom to put it up so we have something to attach a prosthesis to. We do chemo, and then if we can't, we do amputation. Stem cell doesn't do anything. We have to take that cancer bone out, the whole thing. All of it must be removed. Who are the best donors for a bone marrow transplantation? And that's your siblings. I mean, yourself is good, but most likely it's going to be one of the siblings is the best one. Very little do they have their own already saved. What is the most common opportunistic infection for children with HIV? Usually happens about 3 to 6 months of age. And it's the reason why we want to boost this infant's immune system. That's our goal at birth. And that's PCP pneumonia. Yeah, we've already talked about, you know, the Candida, the yeast, but the most common is the PCP. What would you consider to be neutropenia or a low neutrophil count in children? And less than 500 is really considered that low one. I mean, 500 to 1,000 is lower, but less than 500 is one that you really have to pay attention. And again, good hand washing. A primary characteristic of a brain tumor is what? And the symptoms of headache and vomiting are becoming worse. You don't vomit with eating or occasional. It is, they're getting worse and worse and worse, or worser, if that was a word. A child is receiving the induction of chemotherapy. What does that mean? We know it's given during the first 4 to 6 weeks of therapy. It can be more than one sort of chemo, usually it's several types. And our goal is remission. And then after that is just to eliminate those couple of cells that might be left and then putting them into remission. So Mercy, number 3. Number 2 is my sunflower, and number 1 is my little chicken. Runners up, Sam and Michaela. So what I want you to do is do your attestations, get them done. I will be doing a review at 5:30 for the exam. Again, I will be recording it and I will put it on your announcements, and it will also be on my YouTube channel if you look at it there, okay? So if you want, I'll see you later at 5:30. Thank you, guys.
Thank
Great,
you.
bye.
Bye, Professor.
Thank you.